Thanks for that very kind introduction, Eugene. So as you mentioned, we've been working with this large multi-parametric MRI data set, and I'm going to be speaking a little bit more about that today. So I'll start by acknowledging everyone I've worked with. So Eugene and Aaron, my co-supervisors, all my advisory committee members, all the members of the Wong and Fenster group, our collaborators here at Western, and these sources of funding. I have no conflicts of interest to declare. So I'm not going to spend very much time motivating our work in prostate cancer imaging. If you're present at this meeting, I'm sure you're already aware there are a lot of both diagnostic and therapeutic applications to having both sensitive and specific imaging methods for detecting and localizing prostate tumors. So this is a whole mount histology slide that was taken from a patient who underwent radical prostatectomy as a part of the course of his treatment. The cancerous regions have been outlined by a pathologist and indicated in light pink here. So this is a part of the large ongoing image-guided prostate cancer project that's happening here at Western. So just to give kind of a high-level overview of some of the capabilities that some of the groups here have developed. So led by Aaron Ward and a large number of collaborators, including his former student Eli Gibson, they've come up with this pipeline where they can actually begin with in vivo T2-weighted MRI. A patient that's scheduled to undergo radical prostatectomy will then have their prostate removed. It's marked with strand-shaped fiducials and then imaged ex vivo. And this allows the acquisition of whole mount histology slides that can actually be aligned to the planes of the in vivo imaging. And then through some deformable registration steps, they can actually take this whole mount histology slide after it's been stained and contoured by a pathologist all the way back to the in vivo imaging context. So here I've showed T2-weighted imaging, but you could sub in any other type of imaging modality if you're looking for novel biomarkers of prostate cancer. For instance, a functional parameter map determined for dynamic contrast enhanced MRI, just as an example. So along this line, we've been working with kind of the go-to imaging technique for detecting and localizing prostate cancer, and currently this is multi-parametric MRI. So the most investigated pulse sequences are T2-weighted imaging, diffusion-weighted imaging, specifically apparent diffusion coefficient maps, and then also dynamic contrast enhanced MRI. So while T2-weighted imaging and diffusion-weighted imaging bring a lot of strengths to the table in terms of prostate cancer detection and localization, dynamic contrast enhanced MRI, if analyzed properly, can give us a lot of additional information about tumor vasculature. So this is the imaging modality that I'm going to be focusing on today. So very briefly, DC MRI involves the systemic injection of a paramagnetic contrast agent, typically gadolinium, followed by repeated T1-weighted imaging of a region of interest. So I'm going to play one of these DC MR image sets for you right now. This was acquired at Robarts at 3 Tesla at 7-second temporal resolution. And you can see the prostate in the center of the field of view. As the gadolinium washes in, you'll see the whole prostate enhance. And if you turn your attention to this focal region in the prostate posterior, you'll see it enhance a little more quickly than the rest of the gland. So we associate prostate tumors with increased vasculature, increased vascularity, and increased vascular permeability. So this region of increased enhancement would be a region of suspicion. We can then go one step further and actually plot the signal intensity versus time for each voxel in our image. This could be for an individual voxel or actually a region of interest as well. And just by looking at these signal intensity versus time curves, we can get a lot of information about the rate of contrast uptake and how quickly it's then washing out of our voxel or region of interest. So if you do kind of a quick and dirty literature review of some human DC MRI studies that have taken place over the past few years, this was just kind of looking through the database of pubs I had in my folder. There's a large portion of them that actually do the type of analysis that we just did. So you actually scroll through the DC MR images, you can identify areas of suspicion, and then either just draw in a simple region of interest or look at the individual signal intensity versus time curves to glean some information about where the tumors are in your data set. So there's another class of studies that go another step further and actually estimate the gadolinium concentration that's present in each voxel based on the signal enhancement. And then finally, there's another category of analysis methods that don't really fall neatly into either of these two. They're using kind of in-house software to validate new analysis methods. But just to kind of squeeze this in, we can do some very preliminary analysis on these raw signal intensity versus time curves. We don't make any assumptions of contrast uptake mechanism. We simply look at things like peak enhancement, time to peak enhancement, or late phase slope. And the reason I'm showing you these images is because they're relatively simple to calculate, and we have a roughly co-registered whole mount histology slide here that I showed earlier. And you can kind of see already we're generating quite a bit of image contrast by doing these simple analysis techniques. So you can see like the hypo intensity and time to peak enhancement roughly corresponds with a tumor presence here. So if you just want to create image contrast, model-free analyses are a great way to do that. However, what if we would like to do some more rigorous quantitative comparisons, either between patients, or if we'd like to do some sort of longitudinal analysis where we're assessing something like tumor vascular response to some form of therapy? So we can actually plot this gadolinium concentration versus time. And I guess a limitation of these model-free maps that I've just shown is that the gadolinium concentration that we're observing in this voxel of interest, it's associated with properties of the local tissue. However, it's also a function of how the gadolinium was delivered to that voxel of interest. So if you're injecting a larger amount of gadolinium, for instance, you're going to see more enhancement. And that's not attributed to the tissue itself. It's attributed to things like injection speed and cardiovascular output. So in order to normalize for these types of things, we actually come up with a model of contrast agent delivery and contrast agent uptake, and we call these pharmacokinetic models. So by fitting these types of pharmacokinetic models to our gadolinium versus time curves, we can now come up with tissue-specific estimates of these biological properties such as K-trans and KEP, which roughly correspond to how quickly contrast agent washes into and out of the tissue in our voxel of interest. So doing this voxel-wise, we can come up with nice parameter maps of K-trans and KEP. And you can see that I've now included scale bars on these images because we're much more confident that these parameters are more representative of our tissue of interest rather than combinations of injection protocol and cardiovascular output. However, something that I've kind of gone over quickly is this estimation of how quickly contrast agent is being delivered. So we describe this with what's called an arterial input function. So this is a model of an arterial input function that was determined in a study by Parker and others in 2006, where they looked at a large patient population to estimate what a typical arterial input function should look like. And you'll notice it incorporates things like a very large peak corresponding to our initial bolus injection, followed by a smaller recirculation peak, followed by an exponential decay associated with renal clearance. So we need to come up with an estimate of this arterial input function to accurately calculate K-trans and KEP. However, if we resample this arterial input function at 7-second temporal resolution, so this corresponds to the image set that we were looking at earlier, you can see right away we're missing a large portion of this peak bolus injection phase, and we're really underestimating the amount of gadolinium that's been delivered to our tissue of interest. And this error is going to propagate through our entire analysis. So this is an inherent limitation of our image set. So the message here is that directly measuring the arterial input function, if you look in the literature, you need accurate imaging every 5 seconds or faster. And actually, if you talk to people like small animal imagers, they'll actually tell you you need even faster imaging than this to accurately measure the peak enhancement. So if you don't have imaging that's at 5-second temporal resolution, maybe you want to push spatial resolution or signal to noise, then you have to do something like employing a population averaged arterial input function. So you're no longer getting patient-specific normalization for contrast agent delivery, but you can scale these population average arterial input functions to match things like your injection protocol. So now you can get some form of protocol-specific normalization, which isn't perfect, but it's better than nothing. However, there's also a class of pharmacokinetic models known as reference region models. So these replace the directly measured arterial input function with the measurement of a nearby reference tissue that's been well characterized. Typically, we choose muscle. So by measuring the gadolinium uptake in this reference muscle and making some assumptions about the pharmacokinetic parameters, we can actually get back our patient-specific estimate of the rate of contrast agent delivery. So if we look at our prostate imaging field of view, we have the prostate in the center here, but it's surrounded by these large obturator internus muscles. They're very large and easy to segment. But the real benefit of this type of method is that we're no longer measuring this arterial input function with a large initial peak that has a very high temporal resolution. We're actually measuring a tissue concentration curve. So this is a tissue concentration model that was derived from that initial arterial input function. And you can see when we resample this function at 7-second temporal resolution, we're no longer missing a large initial peak. We're getting a much better representation of the shape of the curve. So we can look at our expected gadolinium concentrations in the prostate and the reference muscle. So we don't expect the muscle to be as vascular as our prostate, so we expect the gadolinium concentration to be lower. And now we're going to be using the relative gadolinium enhancement between the prostate and our reference muscle to calculate our K-trans and KEP. So based on our literature review and some initial simulations we did, we came up with this hypothesis. So we think that K-trans and KEP calculated with these reference region models should not be significantly different between patient groups, even if they were scanned at different temporal resolutions. So coming back to the work at Western, as a part of this large image-guided prostate cancer study, we had these DC MRI scans that were acquired all at Robarts using the same injection protocol, but a subset was scanned at 7-second temporal resolution and another subset was scanned at 93-second temporal resolution. So you can see the trade-off in these image sets. In the 93-second temporal resolution set, we're getting far fewer time points, but the spatial resolution and signal to noise is far superior. So if we think back to our initial analysis, just scrolling through the DC MR images, having some increased spatial resolution, it could be a benefit if you're just doing this form of analysis. But now, since we also have this co-registered histology, we would like to do some more quantitative comparisons. So we really want to calculate K-trans. So jumping right into the results, these were some initial K-trans maps we calculated using this new reference region model. So if you recall, our hypothesis was that K-trans values should be similar between our two patient cohorts. But if you look at the 7-second case, it looks like the K-trans values are actually much lower. And if we look at the average values across all patients in our study, you can see that this is in fact the case. At 7-second temporal resolution, we're measuring much lower K-trans by a factor of between 3 and 4 than at 93-second temporal resolution. When we look at the gadolinium concentration time curves averaged across all patients in both cohorts, you can see that something strange is going on at 7-second temporal resolution. We're measuring very similar gadolinium concentrations in both the prostate and muscle. So there must be something wrong with how we're calculating our gadolinium concentration. So to get to the bottom of this puzzle, we actually have to go back to how our MR images were formed. So MR image formation begins with the application of a very strong main magnetic field. So in these examples, it's going to be in the Z or upwards direction. This causes all the protons in our tissue to act as tiny dipoles, processing at a very specific frequency. It also causes the bulk magnetization vector to tend to align with this main magnetic field. This is the lowest energy state. We can then apply radio frequency pulses, which tip this main magnetization vector away from the main magnetic field, giving us a signal we can measure. Now, this magnetization vector will tend to relax back towards the main magnetic field at a rate determined by the T1 time of the tissue. So shorter T1 times mean that this longitudinal component is going to recover more quickly. Furthermore, the T1 weighted pulse sequences that we're using for DC MRI have signal intensities that are proportional to the length of this Z component of the magnetization vector directly before an RF pulse. So we can actually look at a plot of this longitudinal component of the magnetization vector over time. So in this example, you can notice that it approaches a steady state value very quickly. Furthermore, in this example, this steady state value is very close to 1. It's very close to the maximum longitudinal magnetization. So this would correspond to a voxel with a very high signal intensity. So the reason for this is that the T1 time in this example is relatively short compared to the repetition time between RF pulses. So something we can keep in mind now is that gadolinium presence causes nearby protons to have shorter T1 relaxation times. Okay, so things are kind of making sense. When we have gadolinium presence, we have a higher signal intensity. Now, conversely, let's look at an example where the T1 time is much longer. It's going to take a lot more time for that longitudinal magnetization to recover. The first thing that you'll notice is that the steady state magnetization is a lot lower than it was in our previous example. So this is going to correspond to a voxel with a low signal intensity. The second thing that you'll notice is that it's taking a larger number of RF pulses to actually achieve this steady state value. So if we zoom out on this plot, we can see that in this region, so in this specific example, in the first 10 RF pulses, we're actually calculating a much different non-steady state magnetization than the steady state case. So what determines the number of RF pulses? We can think of this very simply. So if you're imaging a given volume of tissue, the number of RF pulses will roughly correspond to the spatial resolution. So if you're pushing spatial resolution, you're going to have a larger number of RF pulses. So things like parallel imaging can confound this, but this is kind of the rule we'll keep in mind. So if we think back to our comparison between the two cohorts, they not only had different temporal resolutions, they also did have different spatial resolutions. Okay, so maybe by incorporating this non-steady state magnetization model into our calculation of gadolinium, maybe we can get back some more accurate concentration values. So I'll remind you, these were the gadolinium concentrations we calculated when we were just assuming differences in temporal resolution. Now, if we build in this model of non-steady state magnetization, the relative gadolinium concentrations we're measuring are much more similar between cohorts. So this is great. So now this again was the K-trans maps we calculated based on our initial assumption of steady state using those gadolinium concentration time curves. With our updated model, great, we're getting much more similar hyperintensities between our two patient cohorts. Again, looking at our initial results in terms of comparing mean value between cohorts, we had significant differences in terms of K-trans. Now with our updated model of magnetization, we're getting much more similar results. So they're still not agreeing perfectly, but now the difference is within about 50%. So we're getting close to the same ballpark of values. So zooming out, I guess coming back to the title of the talk, the hard lessons learned in calculating K-trans. The way I've presented this, our non-steady state model of magnetization seems like kind of a quick fix to our differences in gadolinium concentration. But, it took us a long time to figure this out. So when we're calculating reference region models, we're really sensitive to these types of effects because we're looking at relative gadolinium concentrations in different tissues. And actually, if we look back to this plot of the human studies that I showed earlier, all of these gadolinium concentration-based analysis methods, they all cite gadolinium concentration method or gadolinium concentration calculation methods that assume steady state. So, looking through human studies, it's really hard to pick out that this is the effect that we're actually seeing in our pulse sequences. And so this may not be a problem for other pulse sequences. It's kind of a complex function of flip angle, repetition time, and whether or not you're using parallel imaging. However, for us, it was a significant effect. So the other lesson we learned, kind of looking at our data retrospectively, was that if you're hoping to do pharmacokinetic modeling, you kind of have to think one step ahead. So before you're designing your MR protocol, you really should be thinking of what type of analysis are we hoping to do with this data. So I can kind of draw your attention to these facts again. If you're imaging too slowly, you're going to have a really hard time identifying that arterial input function. Or you can employ a population average. But this has also another caveat. We can no longer rely on relative gadolinium concentrations like we did in our reference region models. We actually need absolute gadolinium concentration values. And we've done a lot of searching through this, trying to determine kind of uncertainty models on our gadolinium concentrations. And this method known as the bookend method seems to us to be the only real reliable way you can get good gadolinium concentration values in an absolute sense. So it involves actually acquiring quantitative T1 values both before your DC MRI sequence as well as after. And this allows you to kind of rescale all your T1 values to get gadolinium concentrations that are within about 10% uncertainty if you do it correctly. So I presented this data initially to Eugene, kind of showing him, when we're pushing for faster imaging sequences, we're kind of pushing further and further away from the steady state assumption. And the quote that he came up with was, magic always comes with a price. So, we can push for these faster sequences, but then our tried and true assumptions of our pulse sequences may no longer be valid. So, thanks for your attention.